Good evening, everyone. Thanks for your patience with our slight technical difficulties. I think that's just the way it goes lately. So I want to thank you all for joining me tonight. I'm really excited for this webinar just because I think this is the first time we're bringing in a really cool pair to be doing this educational session. So thank you guys both for coming. I am, of course, joined by Dr. Anish Patel, who is with the Brooke Army Medical Center. He is a IBD expert and gastroenterologist there. And we have Venetia Vallabha Patel, who happens to be married to Dr. Patel as well. And she's also the Chief of Women's Health at Brooke Army Medical Center and a gynecologist. So this pairing is really cool. We haven't done this before, so I'm excited to get both of your perspectives on caring for women with IBD. So thank you guys for joining me. I know you'll tell everybody a little bit more about yourselves in just a second. I do want to quickly thank our sponsors tonight. So we do have sponsors for this webinar. Thank you to AbbVie and Texas Children's Hospital for sponsoring this webinar and all of our webinars this year. So thank you guys so very much. Just a couple of quick housekeeping items, and then I'm going to take myself off camera. So we are going to be doing questions at the end of the presentation, so we have quite a bit of time for questions. You're going to type your questions in the question box. So in your little navigation panel that should be over to the side, you'll see a question box. Type it in there. When all of the slides are done and the doctors Patel are done, I'm going to come back on screen and I'm going to ask your questions. So do type your questions in there, please. And then also, after we're done with this program, I'm going to email you all a copy of the recording once I have it uploaded. And I'm also going to send you a survey. So please do give me your thoughts on this webinar. Make suggestions on what future webinars you want to see, because I do listen to you, I promise. And so I want to know what else you want to learn about. So without further ado, again, I'm going to take myself off of camera and make myself muted, and I'm going to hand it over to our presenters. Thanks, guys.
All right. I guess we'll get started. So I'm Dr. Patel, and this is also Dr. Patel.
No, it's Dr. Vallabha.
I'm the better half of the two of us, FYI. So I'm the chief of the division of gastroenterology hepatology and the director of IBD Center at Brooke Army Medical Center. And my wife here is the chief of the Women's Health Clinic. And also one of the staff urogynecologists here at Brooke Medical Center. So this is something I want to thank Alicia for setting this up, and it gives opportunity for my wife and I to get together and do something that's, you know, part of both of our passions, IBD for myself and obviously women's health for her. This is something that we kind of hashed up and kind of idea, so hopefully it goes well. So the topic we want to kind of focus on is ages and stages, women in IBD. This is going to be a multi kind of faceted talk. A little bit of housekeeping, so just like Alicia said, if you have questions, please put them in the chat session. I do have my phone in front of me, so if you see myself or my wife looking down, please don't think we're being rude and answering other text messages. It's probably Alicia sending us questions, but I'm going to try to answer questions. If we have on certain slides, something like that, questions, I want to try to answer them while we have the slides open and available. But any question, you know, please feel free to ask. So what we're going to do is this is going to be a basic outline of what we're going to go over. You know, this is a very intensive talk. Each one of these topics can be an hour, 2 hour long talk itself. I don't think you want to hear me talk for multiple hours. I typically don't want to hear my wife talk that long either with that one. So I think we're kind of in mutual agreement on this one. But you know, my focus, I'm really going to kind of focus on the beginning parts of it. The women's health and IBD and pregnancy. Then I'm gonna have my wife take over and really kind of, you know, her expertise is really going to be more in sexual health and urogynecological disorders. But again, any questions that pop up, and I'm sure my wife will chime in between them if I get something wrong, which I typically don't because I'm the better half, like as I said before.
Clearly perfect.
Yes, I am with that one. So what do we look at? Okay, so I'm gonna. This is going to be a little bit more, my wife's going to really kind of focus more on this one, but I want to give a little bit of an intro from, you know, really my perspective from being a GI doctor. So when it comes to body image sexuality, I will personally tell you from a fellowship, you know, standpoint and from being a staff physician in GI, this is something that we don't tackle a lot, you know, often. I particularly do more often than not because I have someone next to me who's really kind of ingrained in my head. And you know, you're kind of seeing her go through her fellowship and everything like that. I have a little bit more predilection to ask more of these kind of questions. But you can see, you know, a survey done a while back, you know, 20% of physicians really kind of address the idea of body image sexuality. It says down here gastroenterology was more frequent, but the caveat to that one was 100% of it was patient initiated. So there wasn't really a gastroenterologist talking to a patient about this one. I would say we're a little bit skewed at BAMC, kind of the way we do our IBD center, because I'm not shy about asking questions about it. Again, caveat, I have my better half over here that really kind of ingrains in me to ask these kind of questions. So I feel a little bit more comfortable doing it. So when you look at it, really in the early 90s is when we really started talking about how IBD was really a sexual dysfunction. Again, this is a preface. My wife will get into a little bit more details a little further on down the road here. Majority came from Crohn's patients with it. And then really more of the recent studies have shown that about 63% of IBD patients in general do have some sort of sexual activity issue. It tends to be really on the low side. And there's a lot of psychosocial factors. Again, you'll see in a couple slides, coming forward. Some reasons that we see from a GI standpoint, at which I kind of see a lot, is going to be abdominal pain, diarrhea, the dyspareunia, which is going to be sex, pain while having sexual intercourse, and then fear of, having a bowel movement when you're actually having intercourse. Which is obviously going to be a really big concern when you have Crohn's with issues down in kind of your bottom area. So these are kind of just basic things I wanted to bring up, which we preface more about my wife, but it's something that we do tend to ignore, unfortunately. I think that's a problem in GI, and I hope people are getting better. But this is what I teach my fellows, across the board, is to be a little bit more attentive to this one. The topics I'm going to cover too as we go forward is more hot topics that I kind of encounter more in the IBD center. There's obviously more women's health than what I'm going to bring up, but this is something that I tend to have a lot of questions I get when a lot of females come into my office. So when it comes to IBD and cervical screening, this is a big question I always get, is that there is a higher risk. So women who have IBD have a slightly higher risk of developing cervical cancer. Even during pap smears, they have a higher risk of getting abnormalities. A lot of it might be medication driven, so drugs like 6-MP, Imuran, your biological therapies, slightly higher risk of cervical cancer. This is a nice study that one of my good friends at Johns Hopkins did. When they looked at the Kaiser system, so this is, if people don't know what the Kaiser system is, on the West Coast, this is a big private kind of insurance system that they looked at 45% of IBD patients developed cervical cancer, had an increased risk of it. Again, anybody who has cervical cancer, the risk you have is that these are the ones that have abnormal pap smears. So IBD patients do have a higher risk of abnormal pap smears. So what does this really mean? Okay, so what does this mean to me as a GI doctor and how I counsel my female patients? Is that I do recommend it yearly. I honestly recommend a yearly pap smear for my patient. This is where, a lot of my wife's colleagues, one of the general gynecologists will argue with me. This is where I'll send my patients to the OB/GYN clinic and they'll get kickback saying, well, our guidelines say 3 to 5 years. I will tell you, after recommendations in GI, and I think some of the OB/GYN literature, even people on some sort of suppressive therapy, again, the drugs I mentioned before, these are the ones should get yearly screening because of the risk of abnormal pap smears with that one. Again, I try to keep myself updated on a lot of the gynecology literature, and a lot of it's still a little bit gray, suppressive therapy, but this is what we see at least from a GI standpoint. And I have a lot of conversations with a lot of her NPs and her PAs and her midwives about this kind of stuff, and we're kind of getting online. It really isn't a problem, but this is something I would harp on. Any female that is on therapy, I do encourage it. Be proactive. Is that you should be getting a pap smear every single year, just because of the slightly higher risk of developing cervical cancer. Osteoporosis is the big one that I will tell you that we forget a lot, especially GI. Because for us, mostly in GI, when we see these patients, our focus is IBD. All right, so when they come to the IBD center, our focus is IBD. We've implemented guidelines in our own IBD center. We have our own templates that we don't forget to ask about osteoporosis screening for, meaning bone scans to look for bone health. A lot of times I talk to my colleagues in in different areas. They want to deflect it, so a lot of them deflect it to the primary care, deflect it to OB/GYN. I think that's where I bold this in red. That's the wrong answer. It's the wrong answer I give to my fellows. My fellows make that answer, and I say that's the wrong answer. Is that we're IBD specialists. This is still in our realm to recommend it and do it. And I order bone scans for a lot of my patients, a lot of my female patients, my older ones, anybody who's had a long history of steroids, I do order it myself. Treatments, again, this is no different than anything we do. Your primary care doctor can really kind of do it. Education is big. Exercise, trying to do more weight-bearing exercises, lifting weights, calcium and vitamin D are other big ones that kind of focus on. FYI, our dog is very attentive right now. Our children with our in-laws, so you save from them, or at least our dog, you will not be saved from our dog over here, so I apologize. There is a benefit, so patients who develop osteoporosis, these drugs called bisphosphonates, these are drugs that really I kind of lean on a primary care provider to order these drugs more often than not, because I'm not very comfortable with that one, but I will recommend those kind of drugs that help bone health. And you'll see a picture over here what normal osteoporosis kind of looks like, is that, normal, and then this is brittle on the right-hand side of osteoporosis right there. So now I'm going to flip gears a little bit and kind of focus more on IBD and pregnancy. Again, this is not going to be a very in-depth talk. This is going to be very kind of, really covering the surface IBD and pregnancy. But I'm going to focus on a little bit kind of more of the hot topics that I tend to get asked questions. And in a little subsegment in our IBD center, we do have our own kind of embedded preconception clinic. So we do a lot of counseling on pre-pregnancy, even during pregnancy. Like I myself, my nurse practitioner, we do a lot of pregnancy management of IBD in conjunction with a lot of my wife's colleagues in maternal fetal medicine. And we do a lot of coordination with IBD pregnancy. So we're very comfortable doing IBD pregnancy. So this is why, for me, this is a very easy talk to kind of give, because I'm a very proponent of having good care during IBD in pregnancy. So a big thing, a lot of questions I get asked is, from someone who is either planning on getting pregnant or is pregnant, is what is the chance of my children getting it? I think it's a one big question that we always have. That comes from my parents, really, is that what is the risk? So if you look at the bottom here, it's very easy. If one parent is afflicted with it, I use easy numbers because I'm very simple with math. 10-30. If one parent, either mom or dad, has IBD, a 10% risk a child will develop in their lifetime. If both parents are affected, about 30% is lifetime risk. So this is a 10-30 rule. So you don't want to worry too much a child developing, but there is a risk, especially when both parents have it. There is a risk that one of your children has a 30% risk of developing IBD in the future. So looking at fertility, this is a big controversial area a while back. Kind of what happens with females. So the rates of women getting pregnant in IBD, really kind of look at it in the past, it was very low. I mean, you're looking at Crohn's about 40%, UC is about 10%. Newer studies showing about 10% for each for Crohn's and UC. General populations, it's about the same. Maybe it was slightly a little bit higher in the IBD population. Really, the one big one is age. So we all know that if you're 60 or 70 years old, you're probably not going to get pregnant. FYI. Even Jennifer Lopez, when she develops 60 years, she can't get pregnant. At 50, maybe. 60, 70, probably not going to happen. So age is still a big risk. And then that's not any different in IBD patients. One of the big things to remember that just because you can't have a natural way, or you're having fertility problems, if you end up going in vitro fertilization, your success rates are no different than general population. So someone with Crohn's disease who unfortunately can't get pregnant because maybe there's some mechanical problems. Maybe the tubes that send the eggs to the uterus are scarred down because of old Crohn's disease or post-surgical change. Having infertility and going through infertility treatments, your success rate is no different than general population. There was a great study done a couple of years ago. They really showed it, which was very nice. So don't be discouraged that just because you have that issue, you may not be able to go through IVF. So there is good success with it. One of the big things also to colitis, and these are patients who have pouches. So these are the patients that end up getting your whole colon cut out and developing where they have a small intestine here becomes a little pouch. The rates of infertility are a little bit higher, and that's only because of post-surgical changes. Is when you have these kind of surgeries in the lower pelvis, you get a lot of scar tissue formation. The fallopian tubes get scarred down. So it's very difficult to have the egg travel. So these patients end up undergoing infertility treatments, and the success rates, again, same thing. The success rate, even for patients who have the surgery, is no different than the general population. But the one thing I do recommend, and I've had a lot of conversation with my wife's colleagues in the reproductive area, that any patient that Once it ended up having to go through surgery non-emergently, maybe the therapy is ultimately going to go it. I do recommend freezing your eggs. I actually have sent a lot of my younger females where to go to probably end up going through this procedure, end up freezing their eggs for future fertility treatments down the road. So that's something to think about somewhere down the road. Looking at, so these are just gonna be generic things I'm gonna put. So there's actually great guidelines that came out from one of our big governing societies in GI that put some of the IBD and pregnancy experts together and really kind of made a couple, really easy flow charts to kind of go through and what you're gonna do during pregnancy. Okay, so these are the preconceptions. This is before you consider having a baby. What you want to do, and this is something that we do in our own IBD center. We actually have like a pseudo preconception clinic. So myself and my nurse practitioner will see the patient. We'll actually hand them off also. We actually have sometimes I try to have maternal fetal medicine involved too, but maybe a separate appointment. But we have big discussions. I mean, I have a discussion with all my females of, are they interested in having a child? Or do they have children? Are they interested in having more? And we go through all these concepts. I'm not going to go through every single one of these lines here. There's a lot to go over, but I have conversations about, what are we going to do? How's your disease doing now? I do recommend all my females who are considering having pregnancy to be in remission, to have the disease under control, because that portends a better prognosis for you. If your disease is quiet and control and whatever therapy you decide to go on, your chance of getting pregnant are higher, but also having a safe pregnancy is higher. We go through fertility stuff. I go through, I have consultations. I do send all my patients who want to consider pregnancy or have questions, stuff that I can't answer. I do have a conversation with that MFM specialist. I just did a webinar with our MFM specialist with some GI doctors. So we have a great connection with that MFM doctor over here with one of my wife's colleagues. Again, we make sure healthcare-wise, everything's up to date, vaccines, a lot of stuff that OBGYN is going to do a lot of stuff anyway when you're planning on being when you're pregnant or getting pregnant. But I harp on these things again too, and then medication management. We go through. I'm not going to go through every single medication here, but just remember that we have conversations with all our patients about medication therapy. With concerns they have, any questions they have, whether they want to start therapy, all those conversations we have all at one lump. And again, if it takes multiple appointments, we do multiple appointments. It's not an issue with it. Now, if you end up getting pregnant, this is a 9-month plan we have. A lot of all these things we actually have laminated in our clinic. But we go through a 9-month plan. So I sit here with the patient. I go through what we're going to do. First, second, third trimester, we have all these conversations, not only what we're going to do for your IBD, but you're also going to be following with a more specialized obstetric doctor, maternal fetal medicine doctor, doing more monitoring of the baby. We're going to talk about medications, how we're going to manage it, what we're going to do with those therapies. We're going to stop certain therapies. I'm a big harper on nutrition. To me is make sure you get good, adequate nutrition, from protein to vitamin D to folate. All those things are going to be discussed. Also, again, the maternal fetal monitoring during a flare. We have all these. We have open slots for our pregnant patients developing a flare during the pregnancy. That we'll get them in really fast. We're very proactive monitoring of our pregnant patients with it. And then lastly, during the pregnancy is going to be what happens during delivery and the post-delivery era. More delivery. This is a conversation I have not only with the OBGYN specialist, but I also have with the patient. There are certain areas and of a patient that may need a C-section. If you have active fistulas in your perianal area, you're really going to be more benefit from a C-section than a vaginal delivery because of the risk of tears and those kind of problems. Now, again, if you're very well controlled ulcerative colitis or very well controlled Crohn's disease, it's not a reason to have a vaginal delivery. But these are conversations I have not only with the patient but also with the maternal fetal medicine specialist in conversation. We're both together to have the right way to go. I know a lot of my female, a lot of the women come in with the pregnancy plans, and they have the what are they called, the
birth plans,
the 50-page birth plans. And a lot of times I tell them, I think it's great to have a birth plan. A lot of times the birth plan goes out the door when things change. And my wife can tell you that too. My wife takes an OB call. A lot of you can have whatever plans you want, but unfortunately, sometimes the plans have to change, and they have to be a little bit more lenient with your plans with it. And in the postpartum area, same thing. I'm a very big advocate of breastfeeding. If you can do it, do it. If you can't, I mean, unfortunately, don't be discouraged with it. I mean, things happen. Unfortunately, not all people can breastfeed, but formula still won't hurt the baby.
Breastfeeding's a lot of hard work.
Yes, my wife
It's
will
another
tell you.
job.
It's another job. With that one. Making sure the baby's doing well. I mean, I have a conversation with the pediatricians a lot about what vaccines they should be doing, depending on what therapies you're on. Live and dead vaccines are kind of listed over here. And make sure, like, again, for me, developmentally for an infant, like I don't typically follow that because that's a little bit out of my realm. However, when I see these patients on follow, I make sure I ask them, how's the baby doing 1 year, 2 year. I mean, my wife can tell you, I get pictures and emails of my prior patients that have moved on, have gone other places, deployed other places, and moved, and I get pictures of their babies. I mean, I have babies now that are now 6, 7 years old that I'm able to see pictures and do stuff like that. So I secondarily follow the milestones. Not truly following it, but these are something to kind of remember. I mean, the just because your baby's gone doesn't mean you stop your IBD care. So that's the one thing to remember, is that we still have close follow-up in postpartum area. It's tough. My wife would tell you, like I was saying, I saw her. The first few months of the worst part. We have 2 children. In the first few months of the worst, I don't want to remember those first few months because they were torture. But they are tough. But it is. So one thing to remember is that the care doesn't stop, and we don't stop the care from our standpoint. So I'm gonna hand it over to my wife, and you can hear me stop talking for a little bit here from my wife. She has better accent than I do with that one, so that is plus. Sometimes it comes out.
Yeah.
You just let me know. I will manage the screen for you.
Thank you.
Yes, I'll be generous and manage the screen for you with that one, as your nice husband.
So I'm going to talk more about sexuality disorders and more associated with chronic diseases in general. So I was looking up a couple studies, and approximately 43% of American women report experiencing some sort of sexual problems. That's almost 50% of patients. However, only 12% of those patients will actually go and ask for medical advice or even talk to their partners about what else is going on, which I find very interesting, because I feel like if this was on the other spectrum, in the sense of this was a male, it would be 90% of them seeking help. And my husband's agreeing with me. So I think it's definitely something that providers and patients both alike need to be more aware of, just to have that open conversation with their providers. Next slide, please.
Yes.
I have it. I have the dog. So a normal sexual response, as you can see here, it's very complex. So it starts with an anticipatory desire, or that drive, and from there it can go a couple of different ways. But what you'll notice on this chart is most of it is all psychological, with the exception of the physical arousal. So there's a lot of things that psychologically can affect your sexual disorders, and we will go through them. But from your desire, you can have that motivation for sex, then you have that willingness. Next goes into the sexual stimuli, and then the part where a lot of patients would have chronic disease, especially with IBD, that information processing by the brain, that's where it gets stuck. And we'll go more in depth into all the different things that will play into that before you can get any type of arousal. Next. So I broke up, there's multiple sexual disorders. So I broke them up into the 3 most common categories that affect chronic pain patients. There's sexual interest and arousal disorders, and that's any type of lack of interest or arousal for a minimum of 6 months. And all these categories affect patients for at least 6 months. There's the orgasmic disorders, and that's any type of reduced in intensity, delayed frequency, or absence of an orgasm on greater than 75% of occasions. And again, that's for 6 months. And then there's the genitopelvic and pelvic pain disorders, which I specialize more in, which we will go into detail with in just a little bit. So for specifically when it comes to the generalized disorders and arousal disorders, the things that play a bigger impact into patients' lives are anxiety disorders, diabetes, obviously on the physiological side of things, depression, medications that you could be on, because if you're on an anxiety or depression medication, the number one side effect is to decrease your libido. Negative sexual attitudes, any type of neurologic disease which affects your sensations. There's a body image side of it that definitely plays a big role into any type of sexual dysfunction. If you've got a history of any type of breast cancer, gynecological cancer, then you do have some sort of psychological sequelae that's associated with it, as well as an anatomical sequelae. Relationship discords play a very large part with patients that I counsel, along with stress emotional environments, especially with our patients in particular with deployments and family members who are deployed, which plays a very high emotional stress level. And then substance abuse in general will decrease your libido. And with your genitopelvic disorders and pain disorders, I split them up into two categories just so they make a little bit more sense. So your genitopelvic disorders are more of your anatomical disorders, things where there's something else that affects why your sexual function may not be as high as you would like it to be, or if there are reasons that you're more conscious of what's going on while you're having intercourse. So genitopelvic disorders, you've got genitourinary syndrome of menopause, which is a fancy way of saying just menopausal symptoms. You've got vaginal dryness or inadequate lubrication, which is what we see a lot of patients when patients are on steroids or other medications, especially antihistamines. So anything that dries any mucous membrane in your body is going to dry your vagina as well, because that is one large mucous membrane. Your vulvovaginitis, so any type of inflammation, obviously history of sexual abuse is going to play a very big part. Hysterectomy, and more predominantly if you have any type of prolapse, whether that is prolapse of your uterus, your bladder, your rectum, all those things play a part into just sexual satisfaction in general. Urinary tract disorders, urinary incontinence, fecal incontinence, and then postpartum period with breastfeeding. So it's not common knowledge, but when you're breastfeeding for 6 months to a year, when you look at your vaginal tissue histologically, it actually looks like a postmenopausal female, which is why intercourse is more painful during your breastfeeding time. And then premature ovarian failure. When it comes to pain disorders, we talk about pain more as a cyclic event. When you have nerve injuries from trauma, previous trauma, that causes specific anatomical problems. Changes with dyspareunia, discharge, vulvodynia, vaginismus, obstetrical trauma. Obviously, if you have a 3rd or 4th degree laceration, my husband's telling me to explain some of these words.
They're bigger words for you and me. A lot of syllables that I don't even understand.
So when you're having like a 3rd or 4th degree laceration, obviously you've just had a baby come through your vagina, and that's caused a lot of trauma. So the last thing on your mind is putting anything else inside your vagina. So there's a lot of hesitation that comes along with that. Endometriosis, any type of pathology, whether it's ovarian pathology, can cause issues. Fibroids, especially with the location of where they are in your uterus, any type of pelvic adhesions, particularly if you've had surgery before, and then some of your inflammatory disorders as you get older, like lichen planus or lichen sclerosus. Vulvodynia and vaginismus, which are the two things that Dr. Patel has pointed out to me. Vulvodynia is more of just a chronic pain syndrome when you have specific areas in the vagina or surrounding the vagina that cause you pain before anything even occurs. And vaginismus is when you have this onset of a contraction in the vaginal muscles prior to the onset of even having intercourse. It's more of a psychological effect where you've had pain before. And so what your body does is when you have pain the first time, your body automatically goes into this pain cycle. So the next time you have intercourse, you're anticipating that pain. So your brain learns that, okay, I'm about to have intercourse, I'm going to have pain. Whether you're actually going to have pain or not, you've entered into this pain cycle where your body or your vagina contracts just at the thought of having intercourse. And we'll go in a little bit more detail about that, about the different management options. But that plays a big role when it comes to any type of chronic disease. And then we talk more specifically about chronic diseases with, obviously, with IBD, when you've got your Crohn's and your ulcerative colitis, when you have your fistulas, when you have your ulcerations, having intercourse, sexual dysfunction is going to be increased because of those disease processes in itself. If you've had prior surgery, like I mentioned, if you've had vaginal surgery before, you're going to have scar tissue there. That's going to cause some pain. If you've had vaginal deliveries before, for a while, intercourse is going to be a little bit different because there's a lot of healing going on there. With medications, especially antidepressant medications, anxiety medications, they're going to, and antihistamines, they're going to cause a lot of vaginal dryness along with decreased libido. So you need to really look at the medications that patients are on to see, is this one of the reasons that your libido has decreased or intercourse is not as pleasurable as it used to be before. Depression and then body image is huge. If you are not feeling attractive, obviously, whether your partner thinks you're attractive or not, doesn't really matter at that point. If you don't feel attractive, then you're not going to want to have intercourse. So those are all things that we need to work on as a whole. So this slide amuses my husband a great deal. So with a lot of my patients, when we bring up the topic of intercourse in itself, their first, when I ask them about intercourse and is it pleasurable for you, their first reply is 95% of the time is, I have intercourse because my husband wants to have intercourse. And so guys in general, and I'm not going to say every single guy out there, they kind of have a one-track mind. So
I have two. I have a brain.
He has a brain. He has two sides to his brain, apparently. That's what we talked about today in the car. So if you have chronic disease, if you have inflammatory bowel disease, before you even think about having intercourse, your husband may be aroused, but you're thinking in the middle of it, well, am I going to have pain during this? You're fearing, am I going to leak during intercourse? Am I going to leak urine? Am I going to leak stool? All those things are very embarrassing if your partner's not aware of them. If you've got drains in place, if you have setons, which are little catheters that are in place when you have fistulas to help them heal. If you have a stoma and the body image itself, are all things that you're constantly thinking about. So it's hard to think about all of these things and at the same time be aroused and want to have intercourse. So the most important thing is that you need to have this open communication with your partner, especially if you're in a monogamous relationship, and your provider. And the next thing we're going to talk about is a little bit about the different types of management options, and each of these management options could be a lecture in itself. So I'm just gonna go through a summary of them, giving a little bit of detail about each. The big thing on everybody's mind, especially with COVID now, is mindful meditation. And mindful meditation plays a big role with patients, especially with chronic disease and pain disorders. A lot of it is just the anticipation of what's going to occur, just keeping down anxiety, keeping down depression, and just changing your focus on what sexual intercourse is going to be like. So mindful meditation, actually in a lot of studies, has been shown very beneficial to a lot of patients, which leads us into cognitive behavioral therapy. With cognitive behavioral therapy, it's all about changing your perception, changing your perception of how you view something. If you view something as unpleasurable, if you view something as chronically painful, you're obviously not going to be interested in participating in it. And that's a big part when it comes to psychological effect and the psychological response when it comes to the arousal system, is that you need to be there both psychologically and physically, because the two don't work without each other. Sex therapy is another management option where you and your partner or even yourself goes in and talks directly to a sexual therapist and tells them, you know, this is what we're doing. This is what I don't feel comfortable with. How can we change our perception of what we are as a couple? And a lot of people have a great deal of success with this. There's always hormone therapy, and with hormone therapy, it can be, there's a lot of FDA approved hormone therapies and there's a lot of non-FDA approved hormone therapies. With hormone therapies, there's, you can have systemic estrogen and progesterone. You can have vaginal estrogen, which I essentially hand out like candy, and my residents will tell you that if I could put estrogen in water, I would, because I think it solves a lot of problems in general.
I'm not drinking that water.
There's topical anesthetics, which work when it's more vulvodynia, when that's causing more of the pain cycle. There's trials of different medications when it's more of a nerve issue. So gabapentin, TCAs can help dull down when your pain and neuroreceptors are firing too much. And those can definitely help a lot of patients. And then when there's problems like vaginismus, when there's just contraction in that pelvic floor muscle, whether it's secondary to a psychological effect, secondary to abuse, or just previous surgery, we can use Botox to actually numb those muscles, to relax those muscles, but there are obviously side effects that come along with that. So think of a person who can't contract their face muscles because they've had too much Botox, and we've all seen those people on TV. So think about that in your vagina. It's the same idea, except you're relaxing the muscles in the vagina, because if they're not overly contracted, they're not hyperstimulated and they don't cause pain then. And then my favorite is pelvic floor muscle therapy, because I think that is a solution to a lot of problems that people have, whether it's with chronic disease, whether it's postpartum. There's a lot to be learned about that, because I think it's one of those topics that we just don't talk about. It's one, pregnancy, chronic disease, sexuality is something that we don't talk about as much, because it's one of those topics that our parents never talked about, our grandparents never talked about. So it's a hush-hush topic. It's a topic where, you know, your mother could have suffered the same things you're suffering, but you never know, because no one ever talks about it. I, fortunately or unfortunately for my husband, talk a lot about things that I probably shouldn't talk about, and I have no filter in life. So my residents will tell you the same thing. When I have this conversation with my parents, with my patients, my mom would wish also that I wouldn't talk as much as I do about things. That I have a very open conversation with my patients, and they actually appreciate that, because a lot of doctors won't do that. And it's not because doctors don't care, it's just, it's an embarrassing topic for most people.
Yep, and I would say we share a lot of patients. I send a lot of my patients that I kind of screened, and for some reason they like my wife more than me.
Oh, because I treat them. He just gives them medications. Yeah. That's why.
Yes.
So pelvic floor physical therapy. So we have a pelvic floor physical therapist in our department, and she's down the hall from me, and I will tell you she's my best friend. Not just for the pelvic floor physical therapy aspect of things, but anytime I hurt my back with working out, anything, the first person I go to is, her name is Smita. And the first person I go to is, I'm like, Smita, can you fix me? And without a doubt, it always comes down to my pelvic girdle being out of place from doing too many squats or whatever Orange Theory has chosen to put through my body for that week. But at the end of the day, I think a lot of patients don't understand that your pelvic girdle, which is your set of muscles, and which come into play a lot after you have a baby. So before you have kids, if you are an athlete, you learn a lot about your pelvic girdle. You learn all about the muscles, how they impact your lower back, how they impact your posture, your legs, your sciatic pain, your psoas pain, you name it, and your pelvic girdle is probably going to impact it in some way. But after we have a baby, for some reason, when we have a vaginal delivery, our body decides that we want to heal that area because vaginal delivery in itself is very traumatic. And we do heal that area to a point, but for some reason, we don't restart using those muscles again. And so we start using other muscles that we shouldn't be using to accomplish things that our pelvic girdle should be doing. One of those things is contracting and relaxing at different times, especially when it comes to having bowel movements, when it comes to our bladders, when it comes to incontinence. Those are all things that our body used to know how to do, but for some reason after we have a baby or we've had some sort of trauma to the pelvis, we forget how to do those things. And so that's where pelvic floor physical therapy comes into play. At our hospital, we're very lucky in the sense that our physical therapist is very passionate about this. So she actually goes up to our postpartum moms on their first day and goes up there and teaches them the different movements that they need to do, whether it's pelvic thrusts, whether it's different types of doing their squats appropriately, about how to have your first bowel movement, things like that, that most people never learn and you don't know about. And these are all things that she always says, I wish I had someone like me, as in herself, 20 years ago when she had her babies, because she's like, we don't talk about these things and they're so important. The other things that pelvic floor physical therapists can do, they look at your body as a whole approach. They target when it comes to what muscles you are using correctly, not using correctly. They do this with actual just physical touch. They'll do it with a myofascial release, which is a fancy way of saying taking knots out of your vagina. And just like you would, if you have pain in your lower back and you have knots in your back or your shoulder, your vaginal muscles do the same thing. So they're trained in massage therapy and how to release those. They're trained to use biofeedback, whether it's with your abdomen, using the appropriate muscles and how they affect your pelvis, and using internal stimulators in the vaginal area to teach you how to use your muscles correctly, and also targeting specific muscle groups with other devices. So I will tell you, like I said before, the pelvic floor physical therapist, I tell all my patients that if you're going to have treatment with me, whether you're going to have surgery with me or other treatment, I always send them just for a baseline with the pelvic floor therapist, and they always come back learning something that they didn't know before. And so this is where I specialize more in, and that's with issues when it comes to urinary incontinence and fecal incontinence and just prolapse in general. With urinary incontinence, my husband will tell you that when I see ads on TV, when it says, you know, I leak urine with a big smile on my face and this is the pad I'm going to use, it frustrates me to no extent because there's ways of treating this where we don't need to wear pads. Whether it's with surgery, whether it's with different procedures or even medication, depending on what the incontinence is, whether it's overactive or it's stress incontinence, which is more associated with activity. For some reason, as a society, we've just decided that if I have a baby, I'm going to leak urine and that's just that, which is not true at all. There's so many easy ways for us to fix this where you don't have to leak urine, in which case that plays into that whole sexual dysfunction. If you're not worried about leaking urine, intercourse is probably going to be a lot more enjoyable for you. As far as pelvic floor prolapse, this picture amuses me because this is how I view your body when you start having prolapse. So instead of your uterus, your rectum, your bladder being in their correct places, they just kind of dance everywhere around your pelvic floor. And so that's when you start feeling those sensations where things are coming out of your vagina, which probably didn't come out of your vagina before. And so if you are having your uterus coming out of the vagina or prolapsing out, or your bladder or your rectum, Obviously, when you want to have intercourse, it's not always ideal to say, hey, honey, by the way, let me just push this in before we can have intercourse. And that can lead to a lot of embarrassments. So that in itself leads to, with a lot of my patients saying, you know, I just defer intercourse and give whatever excuse I need to so I don't have to have it, so I don't have to have that conversation with my husband to say, you know, my body is changing and I don't know what to do about it. Again, these are all things that we can fix. And then there's that great hot flashes and menopause. Menopause, like I said, if I could put estrogen in water, I think it would solve a lot of problems. But there's a lot of different treatments when it comes to hot flashes, specifically with the vaginal dryness aspect of it, whether it's a moisturizing lubricant, whether it is estrogen, whether it's just using household products like some of the things that my previous pelvic floor physical therapist used to tell patients was olive oil, any type of oil that essentially absorbs, you can use in your vagina as a lubricant. So things to think about. So me and Anisha always talk about, in an ideal world, what would a workup be for someone who has chronic disease, who has any type of sexual dysfunction? And we always come to the same conclusion as that patient should be seeing a GI doctor, especially for IBD, and a gynecologist at the same time. And with the gynecologist, so the gynecologist would be managing more of the gynecological issues, things that we can fix, things that we can help you with, while the gastroenterologist manages the gastroenterology issues, more of the disease process side of inflammatory bowel disease. And that way together, and the one other person on this slide that I don't have is a psychologist, because I think that plays a big role into a lot of things. Because having a chronic disease has a psychological effect in itself. I think a lot of patients don't realize how much stress that plays just into your everyday life until you actually get to talk to someone about it and being like, oh, this is how I'm going to handle this, because it's something that's not going away, instead of pushing it aside. The three together, along with pelvic floor, I think we could probably solve a lot of the problems that our patients are having and have a lot happier patients when it comes to just the whole full body effect. So now it's your turn to talk.
My turn now,
Yeah.
finally. So it took I'm actually impressed that she did this fast with that one. But this is a very fast run through of stuff. So I apologize if it was really fast. It's very tough to do.
And I talk really fast.
And she talks really fast. Yeah, exactly. with that one. But to me, this was this conversation I had with Alicia, my wife, was really kind of just give tidbits. Really kind of get a conversation started and kind of get an idea and really kind of, spell out like kind of what my wife and I do. I mean, and this is not something I send her patients all the time. She's back and forth. We go back and forth, and I think this is a nice conversation to have. Is that we all know that IBD is very complicated. The IBD pregnancy, it's not just the GI doctor. Involved with the OBGYN team, along with maternal fetal medicine, part of the pre-planning. If you had to go to the reproductive, there's a whole conversation we have, and this is something that I've been a big advocate of it. In IBD center, I've actually personally gone to my wife's clinic and really kind of reach out to the reproductive folks, to the MFM teams, and we have personal conversation. I have emails all the time. We have an IBD pregnant patient. I'm sending the MFM doctor an email like, hey, FYI, this girl is here, she's pregnant, she's got IBD, this is what we got. Can you get her in? And really within weeks, she's up in there seeing them, the ultrasound, get everything done, and we have this open conversation routinely about having making sure that the pregnancy goes very well for that patient. And just like you heard from my wife, I mean, to me, sexuality is a huge thing. I think there's something that I'm getting better at it. Like I will tell you, when I was internal medicine doctor, you never open a Pandora's box ever, because that appointment now went from a 45-minute appointment to an hour-and-a-half long conversation, and you're backlogged by six other patients. Again, not an excuse, but unfortunately it's reality. I've gotten better. My fellows will tell you they hate me at times when I open a Pandora's box, but I'm okay with doing it. because I have someone like my wife who I can send who's got more expertise in this than I do, but I'm okay opening Pandora's box. I think that's something that more and more we need to do as we move forward, but it's going to be as a whole system. It's a system problem. I think it's as you know, and I train my fellows to be very open. These conversations, it shouldn't be something you should be embarrassed about having a conversation with, because we all have it. I mean, it's not something that you can do it behind closed door. Fine. That's what, back in the 40s and 50s, what they did. They didn't want to talk about it. Now we're in a new age, and I think it's something that's very important to kind of bring up to the table. And I'll tell you, as patients, don't be shy about bringing it up. I think that's the one big thing that conversation I have with my wife is that patients don't bring it up. And I think it's don't be shy about bringing it. You're talking to a male doctor. Don't be shy. The male doctor might get red and embarrassed and get red cheeks, but it makes no difference. We should be able to address any issues that come along with it. I know it's a quick run through, so I think I wanted to, have Alicia come back on and, open it up to if any questions came through, any questions she had, anything like that one. And my wife put this slide up there, FYI. As you can see, the male has questions, but apparently the women has answers for some way, shape, or form. I'm not really sure. Yeah, well, apparently you have all the answers with that one. So I appreciate it, Alicia.
I concur with that slide. Yes.
You can see the dog's head is somewhat in between here, so I apologize for the dog.
No, I love it. I love it. We love having guest speakers come in. So we have quite a few questions, which is great. So I'm going to start you with backing up to your fertility slide. We had a question about what are some of the reasons why patients with IBD have increased rates of infertility?
Yeah, let me go back to the slide. Yeah, so when you look at it, again, this is, I'll take my own personal clinical experience. Data is data. Papers. I will tell you personally, when I ask questions about why a female doesn't want to have a child, it really becomes, one, the fear of having IBD go to the child. Is they're suffering through their own Crohn's or UC. They don't want a child to be afflicted by the same problem. And I think that's not uncommon. I mean, you're talking to my wife and I. I mean, it's a motherly thing. Like, you don't want your child to have something you do because you want them to be better. I think that's really kind of number one. The second one's always going to be, is it post-surgical issues? Is it scar tissue from the disease itself? I think the other fear I always run into when I talk to my patient is the medications. Is that they're scared that whatever medication they're on is going to affect the baby. The baby's going to have 15 eyes and 4 limbs and that kind of stuff. And a lot of it's just going to be easing them to the medication. I mean, I would say for the most part, in general, medications are very safe. There's a couple few that we obviously are going to be afraid of, but those are the ones at least I run clinically. Those tend to be my experiences with that one. And most of the literature, really, and I'll tell you the literature side, it's going to be more. They kind of focus on more of the surgical stuff. It's going to be more the post-surgical, the severity of the disease. The more severe Crohn's is, which you see, the harder it is because of scar tissue. That tends to be more the data.
Okay, and one of the other questions in here was, is 6-MP one of the medications that is safe for pregnancy and breastfeeding? Pregnancy/breastfeeding, so maybe two.
Yep. So 6-MP, Imuran, those are both, I mean, I don't stop them. If the drug's working, they're doing very well, I don't stop the drug. Through the whole preconception and pregnancy, post-pregnancy is very safe. I mean, there actually been great studies that if you were to Google something, the piano study, just like the instrument piano, if you're going to Google this piano study, you'll see some great data from one of my IBD pregnancy mentors, Uma Mahadevan out of UCSF in San Francisco. She's done phenomenal work with this. I mean, she's done studies where she was able to follow these women who had babies on 6-MP and Imuran. You don't see any issues during pregnancy, post-pregnancy. Up to 5 years old, there's no milestone changes. So I advocate. I think it's a drug is very safe. It's working. Keep it. I wouldn't stop it. Again, if you stop it, remember 6 to 8 weeks to get the drug out of your system. So even if you stop it, say you're concerned that you're at 32 weeks or you're at 38 weeks and I don't want the baby to have the drug on board when you have pregnancy. It makes no difference. It's going to linger in your system for 6 to 8 weeks. So it really doesn't. It doesn't change. It tends to linger.
Okay. Well, and that piano study has been going on for quite a few years now, hasn't it?
Yep.
Yeah, so it's a really longitudinal study, so they've had a chance to really follow these ladies and babies for quite a while to see the effects. I have a good friend who was part of that study, and her baby's now 3, 4. So yeah, it's been a while. So next question is, can you talk vaginal Crohn's. So she said there isn't a lot of research. I think it's underreported. How do you identify it? What specialists should you see? Topical treatments? What would you recommend?
You want to talk about it?
We talk about the Crohn's part of it.
I figured.
I'm going to tell you that I'm going to give you some estrogen cream because your vagina needs it.
Yeah, so I mean, intravaginal Crohn, it's very hard. So if we're talking about more fistulas from the rectum to the vagina, de novo Crohn's of the vagina, extremely rare and underreported. Again, Crohn's can happen anywhere. Okay, so it's not uncommon that it potentially could happen in the vagina. I have never seen it de novo, just completely ulcerated and problematic in the vagina. Tends to be related to bad perianal disease, where the fistula went from the rectum into the vagina, and that tends to be a big issue with that one. Management for rectal vaginal fistula, I'll go more to rectal vaginal fistula kind of stuff. It's going to be you're going to come out the you're going to biologic therapies. I mean, you're going to come out with drugs like Remicade or Humira to kind of hope and pray you can close the fistulas. And the surgical side, my wife a little bit more inclined to that stuff than I am. I know when I talk to my colorectals, I talk to my wife when I have these patients. The surgeries are very difficult. I'll let my wife kind of go into that one. I'm not big into the surgical part of it, what they do, but it's tough. I mean, don't get me wrong. I think it's something if we can hope and pray we can do by meds. I mean, that's kind of the number one way, but I kind of let my wife chime into the surgical route.
Ideally, if you can control it with medications, that is the best way. The reason for it is surgery is, we can do it and we do, but because it's classified as what we call a dirty area because all the fecal continents that are around there, it's one of those post-surgical sites that it's chronically infected. So it's, especially when we do like sphincter repairs, some patients have perianal disease, I will tell the patient it's going to be a 6-month process where we're chronically going to be putting you on antibiotics because it will be infected and it's going to heal over time. So ideally, most surgeries we like when you perform the surgery, it heals well, that's the end of that. But it's not an easy recovery for the patients. And the more surgery you do in that area, the less success rate that you have. And the success rate actually decreases pretty significantly to having surgery the first time to having about an 85% success rate to a second time being 30%. So that's why we try to avoid surgery for as long as we can. And then the medication is probably a better route, but it's just based on the location that we're doing the procedure.
Okay, well, and I would imagine for our ladies who have vaginal Crohn's, those are probably the ones that we're looking at, their doctor is really looking at doing a C-section birth versus a vaginal birth just to kind of make sure they're not.
If they have active disease, yes. If your disease is well controlled, then we're always going to say vaginal disease or vaginal birth is the best way of going.
And I forgot to chime in about the second part. Like, what specialists would you see? So this is going to be a big multi-specialty one. I mean, this is going to be coordination with, someone like myself, an IBD person, with someone like my wife, as your gynecologist, and colorectal surgery. I mean, these are 3 big wigs. You're going to have a nice. The intention is going to be is we've done this before. Is like I literally walk onto my wife's office. I pull up the images from the patient, say, "What do you think?" And she's like, "Well, this is going to be cool." All I hear is oh my goodness. And so then I call my colorectal. Hey, real quick, pull up the images right now on the phone. So we're sitting on a voice call. We're having a conversation all together as multidisciplinary. Whether or not is this worth tackling? Is it going to be tough? What's going to happen? So it's a multidisciplinary. You can't just go to like a regular general surgeon and say, hey, can you do surgery? That's not going to go well.
And surgery isn't always. I know everyone thinks surgeons think that a chance to cut is a chance to cure, but sometimes where you're at is probably better than where you will be post-surgically. Yeah. And so we take all of that into consideration when we counsel our patients about, if we say, surgery is not your best reason why. It's not because we don't want to do surgery. We're surgeons. We love to do surgery. But when you look at the overall outcome and you look at what's best for the patient, sometimes surgery is not the best answer.
Okay. Well, and it sounds like if this is you, if this is, you know, and you are somebody that has vaginal Crohn's or is affected in that area, it sounds like when you're looking for a doctor, it's really important to kind of go in and interview your doctor and ask them who do you work with to do this? Who do you work with? What's your experience with this, to make sure that you're really finding somebody that, like you, has a really good partner, you know, in life, but also in profession, to make sure that they can kind of work with you and they can do what you're saying, walk over to the door and open it and say, okay, here's what I have, and to be calling people up. So I think that's key.
Well, the part, the caveat too, Alicia, is going to be is whoever's listening, you're not going to have it everywhere. Okay, so you're not going to system like my wife and I are in, like a BAMC system.
You're not going to be in a trauma center.
Yeah, you're not going to be in a level 1 trauma center, which is the biggest military, military, treatment facility in the world. You're not going to have it. You're not going to have where I can. I mean, luckily I have my wife here. I mean, lucky for that one. I mean, to me is when you're outside and you part of it, you have to trust your doctor. I mean, I think that's where you have to build that trust level. You have the trust level, but it's also the onerous on the actual doctor. I think this is where we don't hold, and I think this is where part of my soapbox comes to my fellows, is that we don't hold doctors accountable. Is that, the lazy answer for me is that I'm just going to put a guy in consult and have them deal with it. That's the lazy person's answer. The true answer is that, hey, I have Dr. Valab here, who I've worked with a lot. I talked to her a lot with these kind of patients. I vetted her. I kind of vetted her. I did an interview, quote unquote, as a doctor. I interviewed her, and you have that connection. I mean, so I think that's where, the problem it is. And there are areas you don't have it. You don't have your gynecologists everywhere. I mean, especially it's just not, and it's hopefully getting built bigger. We don't have it. So I think part of it's going to be onerous on the doctor. If you can't get it, like say you're in, we're in Texas. So say you're in Timbuktu, West Texas, where all you have is cattle, oil, and one doctor. You're not going to find your gynecologist. Ain't gonna happen. Ain't gonna happen. So this is where you get a referral to do you go to like a metroplex like at Dallas or San Antonio and Houston, but that's having that doctor, hopefully having that comfort and that collegiality to reach out and find the best person for it. I think that's what the problem is. I think that's where a lot of people are going to kind of have questions like, well, how am I going to find that person? I'm not going to lie, I don't have the answer. I think it's going to be a little onus. It's really pinning your doctor. It's really pinning your doctor. And again, you have to do your own homework. Like there's fear about using Dr. Google. Don't get me wrong, because Dr. Google has websites and Dr. Google has doctors on there that just make up stuff on the website. That happens because you want to get patients. But I think it's going to be really doing, like you said, doing the interview. Is doing the secondary consult and really kind of seeing it. And don't be shy by asking your doctor is how many surgeries have you done? Like my wife would tell you. I mean, I'm sure people come in her office and say, hey, you look really young. You look like a nurse. You're not a doctor. That's her favorite. That's her favorite comment.
My favorite is like, you look like you just graduated.
Yeah, you look like you're an intern. Like, are you taking my vitals? Is that what you're doing? And then knowing how many surgeries she's done, I think it's not unreasonable to ask.
I think the other part of that also with your surgeon is, we all specialize in different things, and we're all comfortable with different things. And having a surgeon say, you know what, your disease might be out of my league, or what the procedure needs to be done isn't something that I'm comfortable doing. Let me refer you to somebody that I know does this procedure a lot more than me. And there are times when Dr. Patel will come up to me and say, hey, there's this patient can you do surgery on her? And I'll look through her stuff and I'm going to say, no, this is not the person that I should be doing surgery on, but I do know someone who would be good at doing surgery on this person. So I think you also have to interview your surgeon in that way and ask them, if you're not comfortable doing the surgery, are you going to do it anyway? Or are you going to send me to somebody who's done more of these or feels more comfortable doing this?
I still find it funny. She called me Dr. Patel, sitting right next to her. I still find it very amusing with that one.
Talking to people, not you.
Okay, let's see. Next question. I know for some of our folks that have ostomies that are pregnant, there are some considerations, especially, it sounds like maybe automatically they sort of give birth via C-section, but talk to me a little bit about ostomies and pregnancies.
You want to talk about that?
Yeah, that's all you.
No, that's all me. Her parents going to go to me. She did flexible OB stuff now. She's a fancy gynecologist now. FYI. For me, the ostomy management, it really doesn't change between a normal pregnancy. I mean, obviously, yes, ostomy is going to go through changes in pregnancy. Now, I will tell you, I mean, I've talked to MFMs in our institution. They haven't pushed C-sections. So there is no literature or anything supporting the fact that they have to go through a C-section. You can do a vaginal birth with an
It's actually
ostomy.
probably preferable
It's
for
actually
you to
preferable.
do a vaginal birth, just based on the amount of surgery you probably had prior to having that ostomy. You never really know what you're going to encounter when you go into someone's abdomen until you're in it. And so those risks are all at a higher stake when you're actually delivering a baby. So it's actually more preferred for you to have a vaginal delivery if that is possible.
Yeah, and we've done it. I've had numerous ostomy patients who've gotten successfully pregnant with that one, and a lot of them have gone the vaginal delivery route. I think it's preferential. I mean, a lot of them most of them were multiple surgery, like what she was saying is that it's going to be a nightmare to get in there, try to get with scar tissue. It's more difficult than just
your vagina feels a lot better than your abdomen does.
Yeah, because they're all the fear. The one fear that always comes is like, well, I'm doing a lot of pushing. Is that going to blow up my ostomy? Is that going to blow the bowel out of my? No, that thing's sutured in there. I mean, that thing's here to start in there. I mean, you really have to do a lot of damage to get that to change. It's not going to change that. Having a baby is not going to change. I mean, again, you're more pliable anyway, so you have a little bit more laxity. So I don't tell my ostomy patients to be fearful of it. I mean, you can have a delivery just like any other female would with it.
Right. Yeah. Well, and unfortunately, a lot of times by the time folks get to an ostomy, they've had lots of other surgeries before. So like you said, there's lots of scar tissue happening there. So are there any considerations for, I mean, we've talked a lot about kind of ladies in the sort of, beginning half of their life, but definitely, as I age, I realize there's definitely things that come along with getting older. Are there any hormone related things that any of our ladies with IBD need to be considerate of or anything there?
As in, are you talking about replacement, or are you talking about like decreasing the hormone? Like what menopause do, that kind of stuff?
You've gotten the extent of my question, so I'm going to let you interpret that how you will.
Okay. Great. I'm going to lean towards menopause. What happens during menopause? And I'll let that answer that question.
So with menopause, you obviously have a decrease in estrogen, and there was a study done a long time ago called the Women's Health Study, and from that study, everybody has decided that estrogen is evil. So I always tell my patients that, you've grown up with estrogen. It's been in your body your whole life. So there's no reason that it's suddenly become this evil thing that you should no longer need. When it comes to menopause, with patients as you get older, as your estrogen decreases, you're obviously going to have atrophy, which is the thinning of the vaginal mucosa. You're going to have decreased circulation to that vaginal area. But along with that comes more urinary things, with more recurrent urinary tract infections, more overactive bladder symptoms, and definitely more prolapse. So those are all great things to look forward to after menopause. Usually 30 years after your first baby, just FYI. But those are all things that we teach our patients that, don't be scared of estrogen, don't be scared of progesterone. Testosterone is one of those things that there are some good studies about it, and then there are some studies out there that don't show as good results and don't show as good data. But what a lot of people are doing as people age is they're just replacing what your body naturally had. And so there's ways of doing that. There's also there's new laser therapies that you can use for your vagina that help specifically for the atrophy portion of things. If you say, I'm not a great candidate for estrogen, and a lot of IBD patients are not a good candidate for systemic estrogen, there's a lot of laser therapies that have actually been shown to increase lubrication in the vaginal area.
Cool. Wow. Yay, technology.
So your vagina can be lasered now too.
Awesome. Yeah. Is that what they call the rejuvenation? I think that's how it's called.
Yes. And Botox.
question for you now, going back a little bit. So speaking of estrogen, is there, and granted, I think I read this somewhere and it could be wrong, so tell me if that's the case. For some of our younger ladies that are on birth control, but that are also having a flare, sometimes that the inflammation can cause it so that they're not absorbing as much of the birth control. Is that, did I make this up, or is this the case? And if so, what do they do about it?
So a lot of things theoretical. That's all theoretical.
Okay.
I mean, again, if you have rip roaring Crohn's more in the like the stomach, or because birth control pills are typically absorbed in the early small bowel. If you have really bad active Crohn's early small bowel, then yeah, of course. I mean, nothing's going to absorb, from iron to B12 to vitamin D to the hamburger you ate, or whatever it is. You're not going to absorb it. That's going to happen in general. So there can be limitations with it. Also, the colitis, you typically shouldn't have a problem because it's not absorbed in the colon. So really, ulcerative colitis patients shouldn't have an issue with absorption with the pills. But I mean, the one caveat I would make, because Venetia just brought it up here, was with the concerns with birth control pills, estrogen, progesterone, IBD. And there have been some studies coming out now that estrogen-based therapies might increase the risk of flares, or in children might increase the risk of developing IBD. There's something and again, I wouldn't go to the gynecologist and say, well, screw you, doc. I'm going to develop IBD if I take estrogen, take a birth control pill. I ain't going to take it. That's not what I'm saying. It's just, if you have a family history, let's say you have mom, dad, brothers, aunts, uncles, whatever it is, has a bunch of IBD in your history, you might want to have a little bit of a concern with it. But again, you want to treat the problem first. If you're having a lot of bleeding, if you're having a lot of issues from a gynecological standpoint, risk-benefit ratio.
There's always an IUD.
Yeah, there's always an IUD also. There's also an IUD that you can potentially use to kind of help with this kind of thing. So just that's something that the caveat part of the question, was it just be concerned about that, because there is a risk with IBD of having that kind of stuff. But absorption wise, it all really depends. I mean, if you have proximal small bowel, this is where you're going to have absorption.
Okay. So follow up to this estrogen conversation. The person was asking, is what's wrong with systemic estrogen therapy and IBD? So it sounds like that's the study you just referenced.
Yeah. So that's the one, is that it's a healthy concern. I mean, there had been studies coming out, a lot of them were controversial initially. There was one that kind of put a bunch of studies together, and they did show that there was a trend toward potentially increasing risk of developing IBD if you don't have it with a significant family history. Number two is if you have IBD, to increasing the risk of flares. Again, it's not like if you have IBD, you're on a birth control pill that you don't have a chance of getting a problem. No, it's a small percentage, but it's something still there. So if you have recurrent flares and recurrent problems with your disease, you might want to look at it. If you're on birth control, you might want to look at the birth control pill. I've done it. We've done it here. I've done it where I've had trouble controlling some women and take my birth control pill, and it slowly does get better. Yeah, not massive numbers. Don't get me wrong, it's not massive numbers, but something but think about it. So that's my concern with when she wants it in the water. One, I don't want to drink water with estrogen in it, FYI. Number two, one. But number two, it is a concern with IBD.
And all the beautiful glowing skin you have, and
whatever. I have glowing skin already.
Out of curiosity, you mentioned IUD. Are we talking about, there's two different kinds of IUDs. There's the hormonal and then the sort of copper version. So is the hormonal IUD also, because it does have estrogen, is that also something perhaps to consider?
The hormonal IUD only has progesterone. It does not have estrogen.
Okay, perfect.
Told you.
Agreed. All right, good. This is an interesting question. Is there a correlation with IBD and acne?
I'm going to phrase this one. There are dermatological things, all right? So where the acne, it's not, there are autoimmune acne, like pustular acne, systemic pustular acne, which theoretically, if you have a condition that's autoimmune, so your body's reacting, you potentially have the risk of pustular acne. So that is one kind of thing you could look at. A lot of the acne and IBD is from prednisone use. It's going to be from people who have long-term chronic prednisone therapy, have high risk of acne. Prednisone increases risk of acne. There's a lot of times when I see my younger, especially like I see no one above under the age of 18, anything above age 18. So like your young adults, a lot of them who are on chronic prednisone therapy, acne becomes a problem. But the only one that I'm really kind of focused on is there's a variant of pustular acne that can be related to IBD. That can be a problem. These are why it can be tough to treat sometimes. These are where some of the biological therapies do help. When you treat the disease and you treat that one, you can treat both at the same time. So that's something you think about. But again, that's typically, again, same thing. It's like, I'm not going to treat the pustular acne. It's going to be me in coordination with the dermatologist. It's typically what we do, and they do. I have one of my good friends is chief of dermatology at Ramsey, and he's the one. I have something that, again, I'm not a skin doc. Like I can't. I mean, if you have something growing on your skin, I'm not diagnosing you. I'm not gonna lie. I'll be completely dead honest. I know my limitations. I'm calling him. I'm texting him. Hey, FYI, I'm seeing his consult. Go see it. And within a week or two, he's seeing it. So I have a good coordination with derm, but pustular acne is the one that we've been working with a lot. That intermittently we get these pustular acne patients, autoimmune pustular acne can be a problem.
Okay. Last question, because we are getting towards the end of our time here. You've kind of answered this question, but I want to just make sure I get both of your opinions on this. How do you recommend finding a doctor that's willing to have a conversation about sexuality? Many of them are not open and think it's not a problem.
This is literally, I literally were driving home to pick up the kids from Banksy, and I literally said, I'm going to ask you a question. And it's gonna be a loaded question. I'm gonna preempt you right now. I was gonna ask her, how can I be a better doctor and ask this kind of question? So I am now going. She's gonna answer that question. She's gonna answer it now.
Well, I think from a physician point of view, like I'm a little jaded in that sense because I'm just based on my subspecialty. It's something that I deal with on a daily basis. But I think for most providers, from that standpoint, I think it's as simple as asking, are you sexually active? And then when the person says yes, then the next question from a GYN standpoint is it with a male or a female or both? Because that leads you into two different paths as far as different sorts of dysfunctions that can occur, whether it's more anatomical or psychological. And then my next question is always, do you have pain with intercourse? And is intercourse pleasurable for you? And that just leads into a whole array of questions from the patients, because they always have a sigh of relief of, thank God that you asked me that question, because I didn't know how to ask you that question. I think it just comes down to, especially when it comes to visiting your gynecologist. I can't really speak when it comes to internal medicine and GI, but when it comes to your gynecologist, everything is open. I mean, we deal with vaginas all day, so there's really nothing that you're going to say to us that's going to surprise us or embarrass us in any way. I think it's just more your comfort level. And even if you start the conversation with a lot of older patients, I know to start the conversation with, oh, I have some vaginal dryness, and that always leads into the topic of sexual dysfunction and why we have vaginal dryness. So those are all things, just be open with your doctor. I mean, that's what we're here for. Like I said, especially with your gynecologist, be open with your gynecologist. I always tell patients, I'm like, if you don't tell me, I don't know. And I will ask you those questions based on just being a urogynecologist, that I will ask you very specific questions about sexuality. But a general gynecologist, if you don't bring up that topic, may not bring up that topic. If you say, I have pelvic pain, well, they're going to address that pelvic pain only. So you just need to just communicate with your physician.
Yeah, and from my standpoint, again, I get a little jaded because, I have her. It kind of ingrained it in me when she was through fellowship, and I got interested in kind of what she did. So for me, it's a very easy. I mean, I do it. I literally ask. I mean, I'm not shy about asking it. And you'll see like my male fellows, they just get all red that I ask the question, like, oh my God. He asked the female, are you having sex? Or are you sexually active? Are you having interest? Any problem with that one? My female ones actually don't have a problem. So it's actually not an issue with my female fellows. It tends to be the guy. But I think it's one of those things. It's always been a closed door conversation, and I think it's slowly as I train my fellows, and as we get out there and kind of get more open, I don't think it's a wrong conversation to have. And I think and it will. I mean, it's generational. You'll see if you're a 60-year-old doctor,
you're not going to have that.
You ain't going to have that conversation. I'm going to flat tell you, you're going to bring it up, and the person's going to go, nope, not going to happen, not going to happen, and they're out the door. Your younger ones, like my wife and I are in our mid to upper 30s. It's a little bit more open for us. You look at more younger. I mean, my fellows in fellows in their late 20s or 30s. It's not an issue.
I think it's more of a cultural shift that we're having.
Yep.
I mean, our household is probably not the best example because my 2-year-old daughter says vagina. So
that's her fault. She did that one.
Name anatomical parts correctly.
Yes.
So I think it's just more of a conversation that people need to have, that just to be more open about it. And I mean, and it may be that you're uncomfortable from a female point of view to ask your mom to be like, hey, do you have any of these issues? Because this is what I'm having in a roundabout way, and you'd be surprised what your parents will tell you.
Yeah, but I think just like Nisha said, a lot of times, unfortunately, it's going to be the patient bringing it up. And unfortunately, that's the way it is. It's unfortunate how the practice it's just the way the system is, just the way we are. I mean, I'll tell you, Europeans are much different. Europeans are much open. I'll tell you, like I have colleagues in Europe, and they have no problems. Like just walking in the doors, like, hey, how's it going? How's the bed? Doing good? Everything good? But it's not an issue. It's a cultural thing. I think it's more of an American kind of thing. But I think it's more to be proactive. Because I think a lot in IBD and a lot of kind of what Venetia does is you have to be the proactive person. And I encourage it with all my patients to be proactive. You might be the pain in the butt patient that we all talk about. Like, oh, she went to Dr. Google, torture. But that it doesn't bother me because you're proactive. I think being educated and knowing what you want and knowing your conversation and not being embarrassed about it. So you shouldn't be embarrassed to go to your doctor and say, hey, look, this is what I think about my body. This is what I think about, when I having, my husband and I, or my wife and I, whoever your partner is, we're not intimate, we're not having problems. What can we do? And again, that is where, I am not the expert. I'm not. I bring it up and I say, okay, well then let's see. Let me send a consult to my wife. Let me send a consult to psychology. And kind of do that one, but also work at the disease part. So I think it should be multifaceted, but it should be more, unfortunately right now, it's going to be patient directed. But don't be shy. Don't be shy about asking me.
Yeah, well, like you said, if you don't say it, you can't work on it, and your doctor can't help you. And frankly, for both of you, I would be shocked if you'd ever be shocked by anything that any patient says. So
I deal with butts and poop, and she deals with vaginas. I can't imagine. I mean, there's really nothing you're going to bring to my table or table that you're going to embarrass us about. I'm not going to lie. There hasn't been anything. Sure.
I deal with people peeing on themselves and pooping on themselves all day. So
yeah,
there's nothing you can say that's going to embarrass me.
No. We have a fun life.
Indeed. Well, thank you for sharing a little piece of that life with us tonight. We really appreciate that. It was fun to have you guys both on and to hear you, talk about how you work together, but also really talk about kind of your specific areas of expertise. So I want to thank you guys again so much. I want to thank everybody for joining us and sticking in there. I think everybody that was attended up until this very moment. So thank you guys for hanging in. If you have additional questions, you have my email. Just email me, and I can pass that on to our presenters and get you some answers. So if you had some questions you didn't want read out loud, that's totally understandable. Send them on to me. I'm happy to do that. Again, I'm going to send you a survey afterwards along with a recording of this session so you can watch it again if you're interested. I want to do one final shout out, one final thank you to, again, Texas Children's Hospital and AbbVie for being our sponsors for this webinar tonight. So thank you everyone so much. Have a great night.
Thank you all. Appreciate it. Thanks, Alicia.
Bye guys. Thank you.